So, welcome to BillMed. We are today taking the interactive question and answer sessions. This is not a course over here, what we are taking right now. This is the question and answer session for those who are registered with us for different courses. This is not a course, I am repeating, this is not a course what we are taking right now, but this is a question and answer session for those who are registered with us. And those who are able to hear my voice, they have already joined with audio, else you have to join with audio. So you have to join with audio. If you are able to hear my voice, then you have already joined with audio, else you have to join with audio. That is what it is written over here. So this is not a training course, but this is a question and answer session for those who are registered with us. So repeating for the last time so that there will be no confusion, we will entertain questions from those only who have registered with us and are undergoing different server-based courses. And I would like to have some raise hands. What I mean by raise hands, you have to go to the more option and you have to click over there, raise hand, not this physical hand you have to raise. There is an option in more to raise the hand. You have to raise the hand only and only. Please, registered candidates raise their hands. And make sure that you don't have any background noise, because if you'll be having any background noise, then whole of the class will get disturbed from your background noise, whatever will be there. Okay, so let's get started. So today we got some questions from our registered candidates. One of the registered candidate is Dr. Mayuri Sharad. This is the name over here, and these are the questions which she is posting us. She's undergoing a course with us. What I can make out that she is undergoing, probably we are having a lot of registrations. That is what is confusing me for which course she is registered. Probably for gynae she is registered. That is why she is asking these questions related to the gynae ultrasound. So the first question from Dr. Mayuri Sharad is that how to identify adnexa and fallopian tube on ultrasound. Second is how to measure thickened tubal wall and ovarian veins. These are the copy pasted questions. We have just copied and pasted it over here. These are original questions posted. I mean, the language is original. We have not edited it. How so? What I can make out that she wants to first differentiate how to see for a tubal wall whether I am having a tube thickened or ovarian veins in adnexa. Third is the differentiation between the acute and chronic salpingitis with OHSS and PCODs. So the point here is that she wants to confirm, she wants to discuss with us how to differentiate an ovarian hyperdiscrimination syndrome, PCODs from a salpingitis. What she is writing that because both is having the cogwheel appearance and the Bedon spear pattern, that is understood. So ovarian mass and tubo-ovarian abscesses differentiation, probably she's asking, yes, UAG of ovarian masses. And so these are the questions from Dr. Mayuri, which we will take. Then the next question from Dr. Namita is how to differentiate between endometrial hyperplasia and carcinoma, and also when to label an endometrial hyperplasia or thickened endometrium. Very good question, because at times we are having a thickened endometrium. We have to differentiate whether we are dealing with a hyperplastic endometrium or just a thickened endometrium. And I would add one more point over here. What we have to discuss is that why not to different? Yeah, this is here, the carcinoma. So the point is here that in carcinoma and in hyperplasia and thickened endometrium, the picture is overlapping. How to differentiate it? Next candidate, registered candidate is Dr. Mithilesh Bansal Palwal. So I don't know which one is the surname. Dr. Mithilesh is asking how to measure the cervical length, how to see for the cord round neck, and whether this is 1, 2 or 3 loops, how to know wrong dates or IUGR. So he wants to differentiate a wrong dates from intrauterine growth IUGR, how to focus pancreas and the see, we are having a detailed session in the server-based courses, how to focus on the pancreas. So let's do today one thing. We'll not go on to the whiteboard, digital board, I mean. So usually what we do for these questions, we are going to the digital board. We are explaining it over the board or on the PPT. So let's today take these things on live patients. So we have set some patients over there. We will now set the patients and we will discuss. I have noted all these questions. So we will try to take these questions on live patients. So give us 2 minutes to set the patients. Mayuri,
Yes, sir. Yes, sir.
You are registered with us.
Sir, I have registered for advanced fetal course.
Advanced fetal course. What is your qualification?
Sir, I finished MBBS and MS OBGY.
So your MS OBG, okay. Dr. Sharada.
Yes, sir.
You are registered for which course?
Complete OBG course, sir.
Complete. And what is your qualification?
I'm MS gynecologist, sir.
MS gyne.
Yes,
Okay.
yes, sir.
Dr. Ram, if you can hear me? No. So there is some issue with Dr. Ram's audio, not from our side, from his side. So with me are 2 registered candidates, and I can see that we have crossed the 100 limit, and we will now lock the class. Okay. Dr. Mayuri.
Yes, sir.
We are taking class, not the class, we are taking the this question and answer sessions today, right?
Yes, sir.
So this is not a course, this is a question and answer session for those who are registered with us for different courses. But now I have got some questions. Let me show you the questions first. So the questions are, these are the questions. Okay. Yes. First, let me take this first. How to differentiate an endometrial hyperplasia from carcinoma? Are you getting the question from Dr. Namita? This is on the screen. Now,
Yes,
Dr.
sir.
Mayuri.
Yes,
now,
sir.
let us discuss this. I don't believe in teaching only. I believe in discussion. So the first point is that how we can differentiate an endometrial hyperplasia from carcinoma. How can we differentiate a hyperplasia from carcinoma, Dr. Mayuri and Dr. Sharada? Sorry, Dr. What is your name?
Dr.
Huh?
Sharada. Sharada.
Can you spell it out?
SHARADHA. Dr. Sharada.
Sharada. Okay,
Yes.
Dr. Sharada, what do you
Yes,
think? How can we differentiate an endometrial hyperplasia from a carcinoma?
So in endometrial hyperplasia, the endometrial thickness will be more than 14 mm.
First of all, the age.
Yes, sir.
Is age not important over here?
Yes, sir.
Age is very important. Yes, please start from the age.
in the perimenopausal age group,
Very
if
good.
if the endometrial thickness is more than 14 mm,
Mhm.
then we label it as endometrial hyperplasia.
Okay, now if I am having a postmenopausal patient
Uh,
and I am having a 10 millimeters, you told me 14 for perimenopausal, but if I'm having a postmenopausal patient and the endometrium is 10 mm, will I worry or
we need to
that
worry,
is
sir,
okay?
because in a
Yes.
postmenopausal, that's why it is in a perimenopausal, it is
Mm-hmm.
14 mm,
Mm-hmm.
whereas in a postmenopausal, it should be, if it is more than 4 mm, then we call it
Yes.
as
So
endometrial
5 is the cut.
hyperplasia.
Okay.
5.
So 5 is the cut. So first of all, I have to see the age. And I
Yes,
have
sir.
to see whether I'm dealing with a perimenopausal or a postmenopausal patient, right? So 5 is
Yes.
the cut for the postmenopausal. Now, what is important over here is first age and second is the color Doppler.
Mm.
So if I am having a thickened endometrium plus the age is also telling me that I have to go on my toes, then I will put a color. And if
Okay.
there is abundant of color, I will think on lines of CA. Now, those were 2 points. Third point is if there is triple line endometrium, I'm not talking of now of a postmenopausal. If there is a triple line endometrium, will I worry or I will be relaxed? Think. Are you getting the question?
Yes, sir. We need to worry about.
If there is a triple line endometrium, will I worry? Will I think on lines of CA?
For a
Yes or no?
postmenopausal, sir.
Perimenopausal.
No.
Yes or no?
No need to worry, sir.
Yes, this is the point. Now see, if I'm having a triple layered endometrium, it means that the layering is intact. If layering is intact, it means that there is no invasion. You getting the point now? Now,
Yes,
if I am missing the layering, then I am putting the color, not all, but some part of the endometrium is taking more of color, then I will worry. So this is the point when I have to think on lines of carcinoma. Now the second point is how to label, when to label. This is an endometrial hyperplasia, not a thickened endometrium. Dr. Sharad.
Yes, sir.
I'm very sorry, I'm not pronouncing your name in that way it should be.
Okay,
Yes,
sir.
Dr. Sharad. Sharada. Okay,
Yes, sir.
Dr. Sharada. The point is when I can make a diagnosis of endometrial hyperplasia, not a thickened endometrium.
Okay,
First of all, what is endometrial hyperplasia? What is endometrial hyperplasia? There is some ratio. Now, understand first, ultrasound is not about the pictures. Ultrasound is the real test of your brain. What is endometrial hyperplasia? Endometrial hyperplasia, we taught you that there is some ratio between the glands and the stroma.
Yes, sir.
Now, if that ratio is not what there should be, it means that there will be more of glands than the stroma. Yes or no?
Yes, sir.
Will you expect some fallout ecotexture areas? I mean some small cystic lesions if it is hyperplasia, yes or no? Because
Exactly.
this gland to stromal ratio is disturbed.
Yes, sir. It will be there, sir.
Now, if the endometrium is showing some cystic lesions in it, is it going in favor of endometrial hyperplasia? Yes or no?
Yes, sir.
This is the point.
Yes, sir.
Now, you know the things, but the point is our job is to make you understand what you are knowing. You are knowing the things, but now we have to implement the knowledge on ultrasound. Ultrasound is not the game of pictures, but this is the implementation of what you are knowing onto the image. This is the point. Now, let us do one thing. Why not to go to patients? We will now show you the real patients, Now we will show you some real patients. This is the part and parcel of our course. This is not a course what we are taking. So this is a question and answer session, and we will now show you some patients. So we are setting the patients for you. Michael, get Michael. So yeah, you please raise the hand. I will unmute. Raise the hand. So Michael,
yes, sir.
Ready?
Yes, sir. Ready,
Yeah.
sir.
So now we'll be scanning some patients and we will be showing you live patients. This is the probe. This is the control panel. And these are the two monitors. What else you want? If you will come in campus, you will see either how to rotate the hand, or you will see the control panel, or you will see the image, I mean the monitor. And here we are showing you two monitors, the control panel and the demonstration of the probe in one screen only. Now, hold on.
Holding, sir.
Yeah. Now, Dr. Mayuri,
Yes, sir.
which ovary is this, right or left?
Sir, it is right, sir.
This is right. Now, Michael,
Yes, sir.
roll over.
Holding, sir.
Now see, right now I am scanning, I am seeing an ovary over there, which is a right ovary. Now, to see the left ovary, I will go towards the right side or left side? Dr. Mayuri, to see
the right side.
other side, to the other side. Hold on, Michael.
Holding, sir.
Yeah. Now,
To
Dr.
see
Mayuri,
left side, you will go on the right side and tilt
this
the
is
probe,
which
sir.
ovary? This is the left ovary.
Left
Am I
ovary.
right or wrong?
Yes, sir.
Now this is left ovary. See where Michael's hand is.
On the right.
On
Right
the
side.
opposite side. What it means? It means that you have to send the beam through the bladder. Then only picture will be clear. Done? So this is the basic thing which you have to know. Michael,
Ready, sir.
start.
Ready.
So now see, the beautiful ovaries are coming over here. This is not a high-end machine. This is the basic machine. So now, if I am dealing with the PCODs, the question was from PCODs also. If I am dealing with PCODs, what are the criteria, ultrasound criteria on monitor to label this as, hold on, Michael.
Yes, sir.
Now, coming to the endometrium first. Now, I have to see to this endometrium. If there is triple layering, then it is going in favor of endometrial and thickened endometrium, if it is more than 14 millimeters. But if in this endometrium we are having some cystic lesions also, it means that the gland to stroma ratio is disturbed. Then we can label it as endometrial hyperplasia. So I am hitting both birds with the same stone. I mean, I am showing you patients also, and I am giving replies to the questions also. So, roll over.
Yes, sir.
So, let us set next patient.
Okay, sir.
Michael, next patient.
Yes,
please.
sir.
So, before next patient, this is the endometrial thickness over here. Now, see the endometrial thickness. In endometrial thickness, you have to include the endomyojunction also. You have to include the endomyojunction also. This is the cervix here, this is the cervix, and this is the fundus over here. This is anti-clockwise rotation. That is why fundus is onto this side. This is anterior, this is posterior. This should have been superior if this would have been an clockwise rotation. But this is inferior over here, and this is superior over here, because this is an anti-clockwise rotation, which we have discussed the physics and machine settings. So this is the ovary in this patient. Now, Dr. Mayuri.
Yes, sir.
What I am seeing over here, which part of ovary is this? Which part of ovary is this? This. Can you see the arrow?
Yes, sir.
So tell me which part of this.
This is medulla, the center part of the ovary. Medulla.
Yeah. So we call it stroma,
Medulla.
right?
Stroma.
Yeah. Now in PCODs, we have got a question of PCODs also. That is what I am hitting also PCODs. If I am having not a prominent stroma, I will not think on lines of PCODs. But if I am having this part, this central part, very prominent, should I think on lines of PCODs? Yes or no?
Yes, sir.
Yes. So the question was how to differentiate a PCODs from ovarian hyperstimulation syndrome. First of all, in ovarian hyperstimulation syndrome, there will be a history of
Ovulation
induction drugs.
Induction drugs. And if there is history of, then there will be many multiple cystic lesions. Where will be the ovarian parenchyma that will be pushed in between the multiple cystic lesions, and on putting the color, these areas will take color. Actually, this is a pushed and this ovarian tissue in between the cystic lesions in ovarian hyperstimulation syndrome. That is one point. Second is, first was that I will be having a history. Second is what we have discussed. And the third is there can be ascites, there can be pleural effusion also. Okay. So this way we can make a diagnosis whether I am dealing with this or that. So, but no way there will be a central stromal hyperplasia in case of ovarian hyperstimulation. But if it is the case of PCODs, then it will be. So let's set one more patient. Michael?
Ready, sir.
Ready?
Ready.
Okay. Now, let's take next patient. Now, what is this patient about? Even I don't have any idea what is this patient. Yeah, first of all, see, this is not a thin patient, but a bulky patient. All of you will say, if I am dealing with a bulky patient, if this obese patient, we have to insert the probe for this scanning of ovaries. Michael, start.
Ready, sir. Ready.
Now, see whether Michael will get ovary in this. Michael, go to the right or the left side and hit it from there. So first of all, he is taking the length of the uterus. Now see, go. Yeah, now see. So can you see the ovary? Can you appreciate the ovary, Dr. Mayuri, here or here?
Not very. Yes, sir. No.
Now
Yes, sir.
see.
Yes.
See. Zoom it. Yeah. Can you see
Yes,
the ovary?
sir.
And see
Yes, sir.
how obese patient is. Hold on.
Yes, sir.
Now see how obese patient is. Why we are getting ovary in this patient is that we are sending the beam through the bladder. And now see where the hand is. This is a right ovary. And see where the hand is. What I mean by hand, the transducer, it is on the opposite side, hitting it through the bladder. That is why I am able to see ovary in this obese patient. So the point is no need to insert probe all times. You have to play with some of your functional neurons. So that is, you have to hit the beam through the bladder with appropriate settings of the machine, which we have discussed in the physics and machine settings. I will not discuss it over. Roll over, Michael.
Yes, sir.
So this is the ovary in this patient, very beautiful ovary. Let us see if he will get another ovary also. So now see where the probe is. On the opposite side, on the opposite side. So on the right side to hit the left ovary. So this is the endometrium over here, endometrium coming in between. So this is the uterus in transverse section. Now let us see if we will be able to get another ovary in this patient, in this obese patient on trans-abdominal scan. So pay attention over here. It is coming over here in between. This is the ovary. This is the ovary over here. Probably you will get it. Yeah. So meanwhile, see to the endo also. This is the endo over here. So you will not expect a very clear endometrium over here. Yes, it is coming. It is coming. It is coming. So the point here is that apply your physics onto the monitor, onto the ultrasound, then only picture will be clear, then only you can do ultrasound. So yes, we are getting now, this is the ovary over here, this is the ovary, this is the ovary, this thing, this is the ovary. So the point was that even in this obese patient, hold on.
Yes, sir.
Yeah. Go to the ovary first. Yeah, go. Hold on.
Yes,
So
sir.
the point over here is that we got this ovary in this much bulky patient because we played with the physics and machine settings, and we didn't just put up the probe onto the ovary. We throw the beam through the bladder, and this way it get clear picture. So ovarian hyperstimulation syndrome, endometrial hyperplasia is clear now, and yeah. Okay, Michael.
Yes, sir.
Set any abdominal ultrasound patient.
Okay, sir.
Okay. So now what we will do, we will go to the next question. The next question was about the pancreas. So you being a gynecologist, sometimes your patient, Dr. Mayuri and Dr. Sharadha, sometimes the patient will say that I am having pain over there. Then you cannot say that I am not knowing the things. I will not go to pelvis, from pelvis to upper abdomen. So we'll show you how to scan this pancreas. Michael?
Yes, sir.
Set for pancreas.
Okay, sir.
Okay. So till the time you're setting it. Ready, Michael?
Ready, sir.
Okay. Now start.
Okay.
So you know where the probe is. Now see over here. First of all, hold on.
Yeah.
Now, what is over here? Dr. Mayuri, Dr. Sharadha,
Yes,
you are not registered for abdominal ultrasound, but you should now know what is this. I mean, which structure is this over here?
Stomach.
The fluid is over here. And see where the probe is. Stomach. Very good. So this is the stomach over here. Now see, the point over here is that why that candidate is telling me how to scan the pancreas is that maybe that he has not completed the course. I mean, the pancreas, he has not gone to the pancreatic topic yet, because we are showing you patients over there through server. We are showing you patients through server. These patients are being we are showing these patients via server also. So maybe that person, whosoever has posted this question, has not gone to the pancreatic topic yet. Now, so now anyhow, we have got the question, we have to answer it. The point here is that the stomach, just now we showed you the ovary. If there will be empty bladder, will you be able to get the ovary? No. Same is true for the pancreas also. The window to scan the pancreas is via stomach. If stomach is full, then picture will be more clear. Michael, start.
Yes, sir.
Now here we are having a stomach and we are hitting this area over here. This is the pancreas over here. Now see, this is the pancreatic head. Where is head? Where is body? Where is this tail? This is already discussed in your this server-based courses. So now see, the point here is that we are getting this good pancreas because the scanning window, the window is to the stomach. But here's the catch. The patient should have fluid. Now see, the stomach, the full stomach, not to fill the bladder, but to fill the stomach. Now you will give patient fluid and you will immediately scan, not to wait. If you will make patient wait, then the fluid will escape down and you will see full bladder, but not the good picture of the pancreas. Maybe that doctor is making the patient to make their bladders full, but by the time the bladder is full, the fluid is escaping through the stomach, and he is not able to see the this pancreas. So make sure that the stomach is full, not the bladder here. So I am not concerned with the bladder here. So it means that I have to give patient fluid and I have to immediately scan the patient. Maybe after 2 minutes, maybe after 3 minutes, but not after half an hour. This is the point. So this is how we are scanning the pancreas. Okay. So now let us now, Michael.
Yes, sir.
Hold on. This is not a part and parcel of this question and answer session. What we are doing right now, we are taking the longitudinal sweeps. This is in your server-based courses. The transverse section and the longitudinal section, I will not discuss it over here. It will take about 2 hours. We are having on our server about 4 classes on pancreatic scan practicals only. So what was the next question? So leave this patient.
Okay, sir.
Okay. So let us go to the one more thing was there, the cord round neck. Now see, the point here is that Michael, do we have any antenatal patient? Michael, you there? Michael, come in. Yes, hold on. Just hold on, there is some technical glitch. Then no, Michael, Can you hear me? Ask for unmute invitation. No, it is not coming. This one? This one? Okay, done. Michael?
Yes, sir.
Do I have any antenatal patient over there? Yes,
Yes,
or no?
sir.
Yeah, try to get a quad round neck on one of the patient. Okay.
Okay, sir.
Okay. So till he's setting the patient, we will discuss something on quad round neck. Now see, the point here is that what should be the section to get the quad round neck? What should be the section? Dr. Mayuri. Now
Yes,
this is
sir.
our case quad round neck. What should be the section when I am excluding or making a diagnosis of quad round neck? It should be first of all at the level of this this neck that we know.
Yes,
But
sir.
what should be the section?
Sagittal section.
Sagittal section. Dr.
Longitudinally.
Sharadha.
Transverse, sir.
Transverse.
Transverse section
One is
around the
with
neck.
transverse, one is with longitudinal. So 50-50 chances.
Because on
Now-
transverse section, once we put Doppler,
Who is telling me? Who is telling me transverse?
Dr. Sharada.
Sharada. Transverse. Dr. Mayuri?
Longitudinal. Sir.
Longitudinal. Okay, let us go for a chat. So everybody, please comment in the chat box. I mean the comment box. It is a comment box. Durgesh, is it comment or chat? Chat box or comment box? So there is a comment box. Please post over there whether this is transverse or this is longitudinal. Dr. Mayuri is with chat. It is chat box. Dr. Mayuri is with longitudinal and Dr. Sharada is with transverse section. So the question was, what should be the section through the neck to see whether I am dealing with a quad round neck? It should be transverse or longitudinal. Let us see whether Mayuri or Dr. Sharada is right. In chat box now. In chat box now. Transverse, one with transverse. Wait. Now I am getting Dr. Coco transverse, Dr. Subha longitudinal, transverse, Nidhi, Anita transverse, Dr. Kavya longitudinal, then transverse, Dr. Reena transverse, Dr. Nancy longitudinal, transverse again, longitudinal, long, transverse. Now see your comments. Now see, the point here is that you have to understand what we have to see. So let's first go to the patient. The patient is already set. Then you will get a reply of your answer. Michael?
Yes, sir.
Ready?
Ready, sir.
Done. Start.
Okay.
Now, first of all, what we are trying to get, first the length of the spine in, of course, in neck area. So this is the long. Hold on.
Yes, sir.
Yeah. Now, this is the longitudinal section. Longitudinal section of spine at the level of the neck. Start.
Yes, sir.
Now, this is the longitudinal section. In longitudinal section, I am putting the color box. Now, see, I am putting the color box. Then we are rotating. Hold on. Very good, Michael. Very good. Now, see. Start again.
Okay.
You are very lucky that we got a quad round neck over here. Start again.
Okay, sir.
Now see, First of all, longitudinal section. Dr. Mayuri,
Yes, sir.
you told me longitudinal section. You have
Yes,
put
sir.
your color box in the longitudinal section, and can you see any cord round neck over here?
No, sir.
Now, Michael, start.
Yes, sir.
Now, we will rotate the probe. We will rotate the probe to get the transverse section. We'll get the transverse section. So once you have adjusted it, now see it, rotating the probe. Hold on.
Yes, sir.
Hold. Yeah. Now see, in transverse section, now you are seeing these loops coming up. Hold it over here. Now, what does this mean? This means that we have to start from longitudinal section, but we have to end on the transverse section to see whether we are dealing with cord round neck or there is no cord round neck. Now the point is, start again.
Yes, sir.
Now the point is, first of all, is this cord around neck or this is cord around lying just near the neck? Hold on.
Yes, sir.
No, not here. Yes, hold on.
Yes.
Dr. Mayuri,
Yes, sir.
this is the cord over here. In longitudinal section, I can see this much of cord only. Can you make a diagnosis of a cord round neck merely seeing it over here only? Yes or no?
No, sir.
No. So you were wrong by stating that longitudinal. Longitudinal will not show you cord around the neck, but it can show you some loops of cord near the neck. Now there are two possibilities, whether this is a true cord round neck or a cord which is just lying near the neck. Are you understanding my point?
Yes, sir.
Now, I am again repeating, there are two possibilities, whether this will be a cord which is just lying next to the neck, but not cord round neck, or this can be cord round neck. Only and only transverse section will tell me, Michael, start.
Yes, sir.
Only and only transverse section will tell me whether I am dealing with a cord around neck or cord lying next to neck. Okay. So we have taken probably all questions. So now, how many loops are there? That is a part and parcel of our color Doppler. We are taking these things in great detail in color Doppler. How many loops are there? How to make it, whether we are dealing with a tight loop or a loose loop. Okay, let's have a word on tight and loose loop. Dr. Sharadha.
Yes, sir.
How we can make a diagnosis of a loose or a tight loop? First of all, tell me whether you have completed the color Doppler course or not.
No, sir.
No, this is the point. Then
This is
you
the first day, sir.
tell me the right answer. Okay, anyhow, let us see whatever you have been taught in your post-graduation, how to differentiate a loose loop from a tight loop. Okay, tell me if you have any idea whether we are dealing with a how to differentiate between a loose or a tight loop. If you have not completed our physics this course of color Doppler, I am not very much sure whether you know the answer. So only
No,
try.
sir. No, sir, I don't know, sir.
Dr. Sharadha or Dr. Mayuri, anybody?
No, sir.
No. Till the time Michael has started already. Hold on, Michael.
Yes, sir.
Yeah. Anyone in the chat box? Anyone in the chat box? How to make a diagnosis whether we are dealing with a tight or a loose loop of cord? So this will be the last thing which we will be discussing.
Sir, can I give a try?
Can
I give a try, sir?
Yeah.
Will there be a decrease in the diastolic flow of the umbilical vessels?
You are close, but the answer is not that. whatever you are telling me. You are telling me that there will be a decrease in the diastolic flow and thereby it will be there will be a high resistive index. No, but something related with color Doppler. Dr. Mirudula, very good. Dr. Mirudula is our old student. She has completed all courses. She is giving the right answer. Dr. Neha, blood flow decreased. RA increased in umbilical artery? No. Notch in the systole of the umbilical artery? Dr. Anusha, yes. Pulsations in umbilical vein? DP Gangwar? No. Pulsations in umbilical vein? No. But yes, in a notch and notch in this artery. Okay, so this way we can differentiate. So this is a complete course of color Doppler physics, this fetal color Doppler. So it is discussed over there. So now Michael,
Yes, sir.
start the pulse wave now. Okay.
Okay, sir.
Okay. So this is the pulse wave over here. So this way we are taking the gate from vein to artery, vein to artery, vein to artery. So this is how we can make out whether there are two or a single loop of cord. So that is discussed already in the color Doppler course. So now our hair, this is also a part and parcel of color Doppler. Hold on.
Yes, sir.
Yeah. Now see, this is the systole. This is the diastole. If we will be having any notching over here in umbilical artery, that way we are dealing with a tight loop of cord. Now, people may be thinking that there will be some depression in the skin. No, you cannot see the skin because the cord is over there. How can you go to the skin? So these notchings will roll over.
Yes, sir.
So these notchings will tell me whether we are dealing with a tight or a loose loop of cord. So in between, we are going from artery to vein to demonstrate you the flows also. So this is the umbilical vein over here, and above is the umbilical artery. So this is a very big topic of color Doppler, which is taken in detail in fetal color Doppler course. So I hope that we have discussed all questions, and these patients, whatever we are sharing you, this is for the first time that we are attempting any demonstration of patients, live patients online. So this was an attempt to answer your questions on live patients. I hope that you have got your answers. God bless all of you. If you are registered candidates with us, you will get an update of next question and answer sessions in your batch subgroup. I am repeating, if you are just added in any of the BillMed's group, doesn't mean that you are a registered candidate. All registered candidates are having their own batch WhatsApp groups where we are directly in connection with these registered candidates. So registered candidates will get a notification of our next Q&A session. Thank you very much. God bless all of you.
Thank you, sir.